unmute the mic. Got it. All right, so yeah, thanks. That's a great introduction. And I'm Dana Plude. I'm Deputy Director in the Division of Behavioral and Social Research in the National Institute on Aging. And NIA is one of the 27 institutes and centers that comprise the National Institutes of Health. And I'm thankful to the summit organizers for including me and my institution in this important and exciting summit. As noted, our session is focused on the patient and caregiver perspective. So in that sense, we're kind of focused on the end users of health at home technology. And the question is, why does health at home matter to me? And I think the three presentations that make up this session will give you sort of a bit of a taste of the kind of work that NIH is supporting in the caregiver and person space. Where it's important to keep in mind that the patient is also a person with a life and a background. And I think the first presentation today will kind of drive home that point. So each of the presentation heads up an enterprise that's been supported through small business research and development funding at NIH. But NIH also supports other kinds of research and developmental activities aside from partnerships with small business. For now, I'm going to point out that NIH has a deep interest in digital health technologies generally, and the presentations you're about to hear are testaments to NIH's commitment in supporting innovative technology to promote health and well-being. So each presentation will take about 15 minutes, and we hope to have time at the end for a question or two. As noted, please type the questions to the email that was provided, and we'll do our best to answer them. After the three presentations, we ought to have time to dive a little deeper into Q&A. So by you submitting your questions in writing, it gives us a chance to address them not only during this session, but to follow up on any that we can't get to during this live time. So without further ado, I'm going to turn to our first presenter, who's Jay Newton-Small, who's the CEO and founder of MemoryWell, which is focused on person-centered care. And Jay, please take it away.
Thanks so much, Dana. I hope everyone can hear me, and I'm going to just share my screen if I can find the right window. 1 second. This is always the challenge of sharing from home. I hope everyone can see that.
Yep. If you put it in presentation mode, it'll be even sweeter.
There we go. That's what I'm going to try to do now. There we go.
You're running.
Wonderful. So hi, everyone. I am as Jay Newton-Small, and I'm CEO and founder of MemoryWell. I've had the pleasure of working with Dana now for a couple of years on a grant that we're doing with UCSF, which is in San Francisco, looking at the impact of the stories that we tell on post-acute geriatric dementia transitions into long-term care. But really the genesis and where I got started for all this was with my father. So my dad had Alzheimer's, and I was my father's primary caregiver for the last 5 years of his life. Just a little background about me. I was a journalist previously. I was totally not in healthcare. I wrote for Bloomberg News for 4 years, covering the Bush White House and politics. And then I was at 10 years at Time Magazine, covering everything from the Obama White House to the Arab Spring. But like I said, I was also my dad's primary caregiver. And when my mother died in 2011, I brought him to live with me in Washington, D.C. And I was totally unprepared for this. I was, like in my early 30s, I had never caregived like for an adult before like that. And the stress of caregiving can be really bad. In fact, it kills 40% of dementia caregivers. They actually pass before the one they're caring for. And that's a 2002 Stanford study. And so my dad was one of those people who was just really hard to care for. He was a wanderer. He would try to get out of the house all the time. I had to lock him in. I lived in terror of him getting out, especially in the wintertime and dying of exposure. So I put bells on all the doors and I finally got someone in to come in and help me out for a few months. And for a while, it was actually about 6 months, I think, before I ended up putting him into care. And I experienced which I think is very common, a whole sort of host of people coming in. You think you're hiring one person who comes in a few days a week, but the way that this whole thing is set up is that there ends up being at least 2, if not 4 people coming in. Then one might drop off because they have family issues. There's just, all this, there's like a whole sort of parade of folks that come to your house, social workers and all these other folks who are trying to, who are there to help, but also it's really hard and frustrating to kind of have to introduce him over and over again. And my dad was at that place where he wasn't very verbal. He didn't really want to have to, he didn't really interact with them very well. He didn't engage at all. And so I felt like I had to do something to better introduce my dad to other people, because they just saw him as this checklist of problems. He was angry, or he was paranoid, accusing everybody of stealing his wallet. He, we would try to take him to coffee clutches or activities, and he would refuse. And they saw him more as like a diagnosis list than anything else. And so I ended up just writing down his story. And it was about 1 page, laminated it, put it there, just wanted people to get to know him. And he'd been a diplomat with the United Nations, and he'd had such an incredible life. And I really wanted him to be known by people. And I found it so hard to do that at the time when he could no longer introduce himself. And after writing his story, it really transformed his care. 2 of his caregivers were Ethiopian, and they'd had no idea that my dad had actually lived in Ethiopia for more than 4 years early on in his career with the United Nations. And they became his champions. They would sit for hours and ask him what it was like to work with Emperor Haile Selassie and what the Empress was like. And Dad loved it because he still remembered Africa from his early 20s at that point, even if he didn't remember last week or last month or last year. So eventually I left my job at Time and started this company where, we would write the life stories of seniors entering care, whether it's home care or assisted living, long-term care, just to be able to better introduce themselves. A lot of seniors, even a lot of seniors can't, like my father, who, was starting to have aphasia and other problems with finding his words. Or some of them are just really shy. Like, this is the greatest generation. They're not prone to sort of promoting themselves or talking about themselves. And so you might spend years talking with them, caregiving with them, and never know that they served in World War II, or that they were a hero. They did incredible things in their life, or like my dad, were a diplomat, and so being able to find those things that makes them who they are and really meet them where they are was really important for me. And I felt like I had to reinvent the wheel for my dad. And I wanted to be able to help people do that on their own. So we now have a network of more than 1,000 writers across the country. We will interview family members if they can't speak for themselves, or ideally the seniors themselves. Write a brief life story. It's usually just 1 page that you can print out. And then we also have an online platform where you can post the story. Loved ones can add to it, like timelines. And that's because we found that more often than not, the story provoked a lot of questions within home care, within families. Like, wait, you fought in World War II? I want to hear more. Tell me where you served. Tell me about your experience. And so this enabled families to kind of ask those questions and post photos and music and movies and videos, and give people a whole toolbox of places of things to explore and interact over. And we found definitely that their care improves, and I'll go over those statistics in a little bit. Just want to sort of talk to you about how it works. We have, like I said, a network of 1,000 writers. The interviews are pretty brief. We record all of the interviews and we upload them to our HIPAA compliant platform. We have SOC 2 Type 2 security. If it's a medical question, oftentimes in home care, it's not quite at that medical place yet. We then write the story. Interestingly enough, we've started to actually to experiment with Chat GPT, helping us write the story. We're still waiting for a HIPAA compliant version to come out, but for non-HIPAA compliant areas, Chat GPT has actually helped us make the stories a lot more inexpensive. It doesn't do like a perfect life story, and I'll just say, like, it is one of those things where when you set the temperature to 0, meaning there's no like embellishment, it's just going to regurgitate whatever it is you told you in a more concise way, which is what we need. It's a very dry, bare bones kind of experience, but it saves us that time of going through a transcript and having to pull out all this different, like born here, parents were these people, siblings, and all that, and it kind of puts it all in one place. And when you raise the temperature at all, even above, like in the most temperature settings for ChatGPT are sort of 0 to 5. At 5, it's like full on embellishment and lies. And so what starts with a story of Joe is, a carpenter who, like, has 7 dogs and like loves the Red Sox, turns into Joe built the ark that saved the world, with his 2 bare hands. And it's this huge, like, this heroic story, which that's what's the fun thing about ChatGPT, right? But for the purposes of what we're doing, you can't do that. So then we have an editor who'll come back in, look at the story, and reinsert some heart and some humanity into it. Find a great lead, find a poetic way of saying certain things, find a way to tie it through. And then we also retrieve a lot of data from these stories. So we have, and I'll go over this data as we go through it, we can pull an incredible amount of social determinants of health data from the stories, which is a very attractive data set for often a lot of hospitals that home care might be working with. They want to understand what's going on with the patients they're sending home. They want to understand what's happening with like the lives of what they can't see. They can see the clinical side, but they can't see the whole other side. So we can fulfill a lot of those data requests and needs. And then we also have like a what matters set of data that we send with the stories on our platform, which is just a cheat sheet for caregiving, like, their favorite music and movies, their favorite songs, their favorite like foods, like all that sort of lists of activities and hobbies and everything else. So we have a bunch of use cases. As I've said, we're talking about home care right now. We also have worked a lot in memory care. My father ended up eventually in an assisted living unit. In long-term care, as I said, we're working with UCSF to do an SBIR, thanks to Dana, around all of that, and care transitions, understanding that if the story goes with the member or with the patient from an acute setting into a long-term setting, does that ease the transition, especially in an era of COVID where family members can't be there? We also are doing a lot of really interesting work with Prospero Health, a palliative group nationally, and Scan Plans, which is a really innovative Medicare Advantage plan out of California, where they've listed us as a VBID benefit for hospice patients. And so we're working with them to tell the life stories of hospice patients, which is a really, I think, palliative and hospice are natural trigger points to sort of be, reflective and think about your life and want to capture that life for your loved ones. There is a huge impact for these stories, and we've seen just enormous amounts of connectivity, deepening the relationship of caregivers, not just paid caregivers who might not know the patient very well, but also very much family caregivers. Being able to pull yourself out of that moment, and this happened to me all the time with my dad, where I was so stressed out with his caregiving. I was like, I only saw him as like the way he was right then. And sometimes being able to look at that story, it would remind me of who he was when he was my dad. And it just would bring me back to him in ways that I think was really powerful for me. It also, really promotes a lot of well-being, engagement, especially for folks like my dad who had cognitive impairment is really the name of the game. You want to engage them as much as possible. And when you engage them, especially people living with dementia and Alzheimer's, you have to meet them where they are. That's a sort of a classic, I think, thing that everybody sort of talks about in Alzheimer's and dementia. You can't try to force them into your reality. This is all stuff I've learned caregiving. You have to kind of go where they are. And so I would ask my dad, like, how old are you, Dad? And sometimes he would say, I'm 30 or 34. And I'd be like, oh, that's when he lived in Africa. So I knew that was a day where he would respond to the Beatles or Burt Kempfert or anything African. But if he said, I'm 50s, I'm in my 50s. And, I would be like, oh, today's a Simon and Garfunkel and Asia Day, because he lived in Asia in his 50s with the UN. So I was lucky that he always could, until pretty late in his life, sort of say to me how old he thought he was. And that was like my hack to it. But everybody has their own hack in caregiving. And also there's a huge increase in client satisfaction. So for those who run home care companies, being able to give this story is a huge, huge legacy gift. Being able to use this story and show the amount of person-centered care that you're doing is so incredible and important. And it's really one that defines you and differentiates you from others in the market.
Jay, just a few minutes left.
Okay, I'm almost done, I promise. So, as I said, we've done a lot of studies understanding like the improvements of how the stories have better connected with people. Family members say that 80% strongly agree and 20% agree. So 100% of people agree with the statement that I feel MemoryWell story improved the relationship between my care staff and my loved one. Staff believe that 91% strongly agree and 109% agree. So 100% again, that MemoryWell stories can help staff care better and understand clients' needs and wishes. And staff, I enjoy my work more when I know my client's story. 100% agreed. So it's something that people just really love the stories, love the impact. We can deliver them, like I said, in different ways. We can print them out. You can leave them laminated in a kitchen sink. You can access them through our platform. You can also use the timeline, as I mentioned before. There is this SDOH data report, and maybe if people have questions about it, they can ask me in the question and answer section about the social determinants of health data that we collect. And I'm just going to leave it there because, like, I've gone over a lot of the information on this slide, and this is I'm getting a little, I think, redundant here. So I will stop sharing and welcome in the next person.
Jay, thanks a lot. We actually do have time for a question. I don't have access to the email, and maybe Alex or whomever, if there is a question, I think we have time to address it.
Hi, Dana. Yes, we do have a few. One of the questions that came up for us was what controls or regulations are in place to make sure that controlled substances are properly used, monitored, and protected in the home?
I don't know that I can answer that question. That's not one that I would know. Sorry, it's not my expertise.
That's okay. And then we have one more if we have time for that.
Sure.
Is the focus of this initiative limited to infectious diseases, or does it also include at-home screenings for cancers and chronic diseases as well?
So Jay, that sounds like a broader question, but I think we could frame it around what you talked about. And in terms of the life stories, one of the things I find appealing about this is that it pretty much it's agnostic to whatever the condition is. I mean, you're working in the Alzheimer's disease space, but I think anytime you have a patient who is limited, certainly in their own ability to communicate, then having these kinds of stories personalizes that context of care. And that's not a question, it's a statement, but is that something that it seems like that fits what you are cooking?
Absolutely. And like I said, we've been doing work with hospice and palliative, which are really disease agnostic, doing work, with in-home care in general. Even when you start getting into assisted living, 70% of those folks already have some form of cognitive impairment. But in home care, it could be really anything. It could be early stage MS or ALS, or there's really no specific disease. We do tend to focus on elderly, and that is our main focus for the company, but really the stories can be applied in many ways across all of healthcare.
Great. Thanks a lot. Appreciate that. So we're going to move on. And next up, we have Robert Quinn, who's the CEO and co-founder at Patched Medical, which is focused on sepsis prevention. So Robert, take it away.
Oh, all right. Can you guys hear me there? And
yes,
see my screen?
Can hear you, and I see a slide on the screen. Great.
All right. Can you see the presentation now?
Yes.
All right, go team. Whew. Okay, thanks everyone for joining today, especially those of you like me who are on the West Coast, and up early and the brain's a little foggy. But welcome to what the Health at Home session, Health at Home means to me session. My name is Robert Quinn. I'm the CEO and co-founder of Patched. And this is actually a company that I started to save my own life. At Patched, we use deep learning and existing wearables to predict sepsis specifically in the at-home setting. Now, I was asked today to talk about how my own experience sort of interacts with the technology we're building to transform the future of home health. And I want to spend the next 10 minutes talking about my own personal experiences with one aspect of home health that rarely gets discussed. And that's actually its capability to eliminate emergencies. Before I get started though, let me tell you my story. So 10 years ago now, I received the life-saving gift of a liver transplant for a rare liver disease known as primary sclerosing cholangitis. I was diagnosed at 12 years old. And so for as long as I can remember, right, I've been in and out of hospital. I was transplanted when I was 21, and I was released from hospital on my 22nd birthday. But naturally, things didn't go quite as planned. In fact, I went on to develop 18 life-threatening episodes of sepsis. Now, this is a condition which kills every 1 in 6 times. And it is also a condition where early intervention is critical. In fact, once you reach septic shock, for every hour antibiotics are delayed, there is an 8% increase in your risk of mortality. Now, obviously, to survive this is a miracle, but it wasn't just luck. You see, whenever I was developing an episode of sepsis, I would get sore legs and a warm face days in advance. And this foreshadowing was my sign that I needed to get to the hospital, and I would race to the hospital early to be treated. This is the only reason that I'm alive today. And what we realized 5 years ago was that if I could tell I was getting sick and save my own life, we could probably use technology to do the same thing for others. Often in home healthcare, we think about chronic conditions like arrhythmias, obesity, diabetes. But I want you to imagine for a second how the world could be different if we could extend home healthcare to predicting and preventing emergencies like stroke, heart attack, and sepsis. Today, I want to make the case that we as innovators not only have an opportunity here, but an obligation to leverage home healthcare, not just to do the important work of managing chronic health conditions, but to transform the way we think about and maybe even eliminate emergencies. And I hope you leave today with a different perspective on what is possible. Let's talk about sepsis for a second, which is the area we're focused on. Of the 55 million people that die around the world every single year, 11 million die from sepsis. And the craziest part is that the US Sepsis Alliance estimates 80% of these people could have been saved simply through early detection and intervention. In other words, we could have saved nearly 9 million lives if there was a way to intervene early with sepsis. But we couldn't. And the reason that we couldn't is that 87% of all sepsis starts at home. At Patch, we solved this problem by combining deep learning and existing off-the-shelf wearables to diagnose the early onset of sepsis, specifically in the at-home setting. Now, the way that this works, if you're a high-risk patient being discharged from hospital, think like a chemo patient, end-stage renal disease, a patient with diabetic foot ulcers, we provide you a wearable for your period of highest risk. Now, this wearable can be any device which measures heart rate, respiration rate, blood pressure, temperature, and SpO2 continuously. This device then transmits that data via the Patched app on a patient's smartphone to our deep learning algorithm in the cloud. We then conduct 27 mathematical transformations of this data, looking for things such as change in heart rate over time, change in blood pressure over time, variability between different measurements, interaction between these changes, etc. And we then feed all of these features, along with demographics and medical history, into our deep learning model. This deep learning model then outputs a sepsis risk score. And when this risk score crosses a threshold, we alert the high-risk patient's treating team, who can then contact the patient and save their life. Now, we've tested this technology in 3 separate clinical settings: the ICU, the ward, and our ultimate target, which is the point of this whole call, at home. We started with the ICU and the ward more as a proof of concept, right? We pulled down existing EHR data, and we looked to make sure we could identify the early onset of sepsis using only variables we could measure at home. And what was super interesting was we discovered that simply by using variables measurable at home and combining this with a deep learning algorithm, we could detect the early onset of sepsis more accurately 8 hours prior to onset than any of the existing standard of care scores were after a patient was already septic. So you were better off with our algorithm 8 hours before you got sick than you were with some of the other risk scores once you were already sick. So once we saw this, we knew that we were sitting on the opportunity of a lifetime. So we set out to test it at home. We conducted a small proof of concept study where we took blood cancer patients receiving their first dose of chemotherapy. And as they left hospital, we provided them all with a smartwatch made by a company we partner with called BioBee to wear for 90 days. Now, this device, like I said, measures heart rate, respiration rate, blood pressure, temperature, and SpO2 semi-continuously. The study was designed to not send back any alerts, because we wanted to see the difference between where we predicted sepsis and then when a patient showed up to the hospital naturally. Remarkably, we were not only able to identify sepsis early in 80% of at-home patients, but what was crazy was that we could actually identify sepsis on average 39 hours before a patient shows up to the hospital naturally. Remember, this is 39 hours for a condition where normally every hour delay in antibiotics is an 8% increase in mortality. And honestly, this is where we are today. Obviously, this is an early stage data, but it's an incredibly promising sign for the future of home health, both for us as a company and for me as a survivor. From here, we need to finish our clinical trial and gain FDA clearance. And this process is moving along quickly. We're actively working with BARDA and NIH to expand our study to a full clinical trial to 5 additional sites. And in that group is MD Anderson, UCSF, and Duke. And our goal really is to have FDA clearance within the next 18 months. And we're currently leveraging our early data to raise our next round of financing from investors. But to round out, I want to give you an anecdotal example of the difference between early and late intervention and the power that at-home health can have. So a few years ago, I was skiing at Lake Tahoe in California. I returned home one evening with sore legs and a warm face, but I'd been skiing all weekend. And so I thought, of course, I have sore legs and a warm face. And so I ignored it. 12 hours later, my blood pressure had gone through the floor. And as I was being loaded onto a helicopter to be flown back to the UCSF ICU room, I was asked if it was okay if they resuscitated me, because I thought that there was a good chance my heart might stop on the flight. Imagine how different this could have been if we'd had a system like ours. Contrast this with Christmas Eve a few years ago. The single worst data in the history of days to end up in the hospital of the year. Of course, I got sore legs and a warm face, didn't I? But under the supervision of my treating team, I was able to start on an emergency box of ciprofloxacin, and I was able to have Christmas with my partner's family. I believe that with technology like ours, this second scenario will be the future. A future where patients don't even need to come into the hospital, and we can dramatically reduce our reliance on the emergency department. The purpose of a summit like this, of course, is to connect people working to change the landscape of home healthcare. So to finish off, I have 3 requests. Firstly, if you know of any other startups attempting to reshape the at-home emergency care space, please let me know. We'd love to chat to them. The second thing, keep holding and going to events like this. We're closer than you might think to a completely different future, especially for emergencies. And of course, finally, as a startup founder, I have an obligatory obligation to ask you if you know any hospitals who'd be interested in this, or any investors who might find this interesting. Shoot me a message. I would love to connect. But to finish off, I want to answer the original question. What does home health mean to me? And to me, home health is the opportunity to live. It's an opportunity to turn someone's life-threatening emergency into just a call with a doctor. And I think it's an opportunity worth pursuing. Thank you.
Robert, thanks so much for not only all the information, but sharing your personal story as part of it. Very, very compelling. I think that you might be able to address a question that came up earlier, and that's the question about, is this technology just focused on sepsis, period? And I think the answer is yes in this instance, but how do you see it generalizing to perhaps other kinds of conditions where, at-home behavior could be monitored to predict some negative outcome?
Yeah, I think so. At the moment, yes. I mean, we are a sepsis company. We're focused on sepsis for now. But I think there's a huge opportunity here. One of the things we're doing as part of this, one of the things that's necessary to solve this at-home emergency problem, is building this pathway, this communication pathway between a patient and their treating team. And that's so exciting because it doesn't really exist today, right? As a patient, if I get sore legs and a warm face, my options are show up to the emergency room, and then they're going to be like, you don't feel well? Great. They're just going to send you home. So I have to kind of wait till I've got a fever. And there's really no way, I can call my physician, but then they don't really have much data. And so there doesn't really exist this pathway for me as a patient back to the treating team to sort of, for an emergency, to say, hey, this is something really serious. Let's see if we can solve this problem. And it's taken me, multiple years to let them know that the sore legs and a warm face is very serious, and it equals a septic infection down the road. And so I think there's a huge opportunity, and what we're really trying to do here is build this pathway. And I think once we've solved, quote unquote, solved the problem of sepsis at home, I think there's opportunity for expansion to other conditions through other deep learning models, et cetera, whether that's through partnerships or us developing it ourselves.
Terrific, thanks. Alex, I don't know if any other questions have popped up. I saw some hand clapping on the screen as you were finishing up, Robert. So I think others joined me in applauding your information and your presentation.
Thank you. Appreciate it. I did see a hand from someone called Karen, I think, in one of the attendees, but that's up to you guys.
Actually, this is Shayla. I was wondering, really great talk, and I'm so sorry you had sepsis so many times, but I'm wondering what do you think, based on all of your conversations with patients and medical care providers, what is it actually going to convince them to adopt this technology and start using them much more broadly? How much evidence do they need? Is there some sort of kind of internal resistance to adoption of new technologies? Thank you.
No worries. So this is a really interesting question because there's multiple stakeholders here, right? Like there's the patient, there's the provider, and there's the, there's ultimately the insurer as well, right? Like, and the insurer, the case is very straightforward financially, right? Like every patient that ends up with sepsis costs them a bundle. For the patient, the case is fairly straightforward as well, right? Like a lot of these patients, very high risk. A lot of them acknowledge the fact that sepsis is a big challenge for them. There was a really interesting finding for me is that particularly in chemotherapy, a lot of them, once their doctor explains it, understand the risk for infection and ultimately sepsis. The clinicians are probably the most interesting group here. And obviously physicians are very evidence driven, right? So, peer reviewed publications, how many exactly we need? Great question. But I think what we've noticed, the biggest driver for providers, provided there's sufficient evidence, right? Once you pass the threshold for sufficient evidence, is the fact that if you're on service as a physician, you're going to receive every single night you're on service 2 to 3 calls for a patient developing sepsis. And so there's this huge motivation, completely unexpected, completely unrelated, of like, maybe you get to sleep through the night, right? Because if you're predicting sepsis 39 hours beforehand, this treatment can then be delayed to the next morning, right? Like you can then bring a patient into the normal course of care and it's no longer an emergency. And so these physicians get to sleep through the night. And that's been a surprisingly big encouragement to adoption that we weren't expecting. So I think, I don't know if that kind of answers your question completely, but that's certainly how we're thinking about it.
Terrific, thanks. I see that there are some attendees that have their hands up, but I'll remind you that the way to communicate your question is to type it to the email address that was given earlier. And we can try to work through that list. And if we can't get to it during our live session, then we can circle back and get answers to you otherwise. So Robert, I think what we'll do now is pause. We do have some time at the end of the session for other questions, and we can circle back and address some of them should they show up in the email. Thank you very much. So next we're going to go on to last but not least is Gene Wang, who's the chairman and chief scientist and co-founder of Care Daily, which is focused on assistive technology for dementia care. And if people are wondering, hey, what's with all this emphasis on dementia? Well, I am from the National Institute on Aging, and Congress has bestowed on us additional funding to support research on this particular epidemic. So Gene is one of the folks who's gotten some funding to do work in this space, and look forward to hearing what you have to say, Gene. Thanks.
Thank you, Dr. Plude. Really appreciate you inviting me along with the other speakers to participate at this very important Health at Home Technology Summit. And
I think Robert might have to stop sharing his screen before you can share yours.
Can you see my screen
there
now?
We go. Try again. So somewhere near the top of the window where perhaps you see me, there ought to be an icon for sharing.
Can you see my screen?
Not yet. We see your whole display right now.
Okay. How's that?
That looks good.
Fantastic. All right. I'm Gene Wang, and I'm the chairman and chief scientist for Care Daily. And as Dr. Plude mentioned, we're very honored to have received 3 NIA-funded research grants, one on developing and evaluating in-home supportive technology for dementia caregivers, And the second that is active now is commercializing in-home supportive technology for dementia caregivers. And then very recently, we were also given a sub-award from Johns Hopkins University for a grant entitled AI Bots and Wearables for Dementia Caregivers to Improve Quality of Life. So this is of great interest to Care Daily to focus on this area where over 6 million people in the US have Alzheimer's or other dementias, and over 15 million family caregivers take care of them. So we're really trying to help during a very difficult process that so many people are going through now, but even more will experience as the baby boomers really age. And because while the good news is people are living longer, the bad news is that so many of us will succumb to this very challenging journey. And I have an 89-year-old father, an 86-year-old mother. I'm the eldest son, and I really am personally very interested in helping for family caregivers take care of their loved ones at home. Both my father and mother are living at home. That's where they want to be. That's where most people want to age, in the comfort of their own homes. And to the extent that we can really improve quality of life and peace of mind, we are really doing something that has great impact and is very valued for not only the seniors who are aging, but their families. Also, it can dramatically change the cost economics. And really, this is something that is very important to achieve as people age in this country and around the world. So the center of our solution is a software as a service. Care Daily really runs 24/7 and focuses on some very important use cases to, in particular, improve peace of mind, reduce caregiver anxiety. And we have focused in particular on 4 areas. One is fall alerts. My mother has fallen 3 times, and fortunately she hasn't really hurt herself, but we are able to not only detect and alert and dispatch, potentially in the worst case, an emergency response, but our AI is able to even predict falls and hopefully stop some of them before they happen. We're also focusing on wandering alerts, because people with dementia sometimes will wander out of their home, and then they can't find their way back. I actually have a good friend who has a dog, which he loves to take on walks, and he does have Alzheimer's disease, which is progressing. And fortunately, they have a dog tracker on the dog's collar, which is how they have found Dan in the past. But our solution has actually helped people understand when somebody has left the home unexpectedly, and we have actually helped people find their loved ones suffering from Alzheimer's disease and before there has been a serious problem. We are also doing sleep monitoring so that we can, for example, produce a sleep score. We track when occupants go to sleep, when they wake up. And of course, lack of sleep is very bad for your mental and physical health. So by really monitoring people's sleep, as well as recommending that they get enough sleep, that can be very helpful for people, not only people who have dementia, but really anybody. And then finally, we are also working to see whether somebody is taking their medicine, and whether, and of course, if you don't remember to take your medicine, that can have serious consequences as well. And so these are some of the most important use cases that our system tracks. And if you take a look at this diagram here, you can see that at the center of our solution are these AI bots. So the bots are not robots. They can't give a sponge bath, but they are software that runs at all times in the cloud that you can add new bots to. So our architecture really allows for very easy addition of new bots to track new use cases. It's a little bit like an app store, in that on your iPhone, you can, or your smartphone, you can actually add new apps and get new functionality out of your phone. This is more like a software architecture app store for your home. And so different people go through different issues and have different chronic conditions. And you can add new AI bot apps to your home to take care of different issues. Coming into the system are basically, we ask people questions on how they're doing, and we can take a lot of value out of the answers that people give us over time. We also collect data from sensors. I don't know if you can see what I'm holding up in my hand, but these are various sensors for tracking things like motion, things like water, things like door openings and closings. And we can collect all of this information, and we can basically see how things are going versus what you usually do. So we track activities of daily life, ADL data, that we can apply. We develop a picture of your typical daily life, and then we can act on it when things don't look right. And then we are also really working quite a bit with things like the Apple Watch, which I have here on my wrist. And this allows us to collect all kinds of biometric data. Previously, for one of our grant studies, we were working with the Care Active Watch, which has the great feature that it has about 6-month battery life, versus my Apple Watch, which, I kind of have to charge every day or so. But other than that, I would say people prefer the Apple Watch. In fact, seniors are usually quite happy to wear an Apple Watch, where they may not be happy to wear a PERS button around their neck because it makes them feel old. And so we are able to collect all kinds of biometrics from these types of devices, and we are able to integrate it together into a brain in the cloud. And we can, on the right side of this graph, do things like turn all of this data into reports. And we can create and email reports to various different groups. We have been focusing on the family, but we are really thinking that as we evolve the product out, we can actually generate reports for the doctors and care team professionals that really could use this kind of information. We are also, like Jay, we are experimenting with ChatGPT, which is an amazing set of technologies. We are HIPAA compliant, we are GDPR compliant, and we really are a very privacy focused and mature, stable platform that is very focused on maintaining the privacy of the data and the personal health information that we're collecting. But we have found that ChatGPT really allows us to write reports that are much more like a human would write. We also support SMS texting so that you don't have to actually launch an app. You can just have a smartphone and the information can come to you in a very convenient way. We're also generating both voice output as well as taking in voice input for this generation that can be much more convenient, as they may not be as familiar with that and not able to type back things on a small keyboard screen. We also have this insight dashboard that is focused more on the senior community use case, where an assisted living facility may have hundreds of apartments with residents in them, and the insight dashboard can very quickly focus on which hopefully small number of residents need some immediate help, and allow the staff to better respond more effectively, more cost effectively. And then finally, we also support various types of cloud integrations, and we are working with some of our channel partners, such as to support direct integration with electronic health records. We're very happy to have just published our first scientific article in the Clinical Gerontologist, which just came out on February 2nd. And in this, we really showed some great results, which is that through these randomized controlled trials, where we had people in the active condition with hardware and services all enabled, and then people in the control condition with all of the hardware, but none of the services except for the water leak sensor enabled. We found that caregivers in the active condition had significantly less anxiety taking care of their loved ones who had some kind of dementia, and that the more the caregiver was interacting with our product, which has been called PPCG, People Power Caregiver product, and the more they interacted with SMS text messages going back and forth, the greater the anxiety was reduced. So we're very excited about these results. We've also seen similar results in terms of the caregivers had less, the quality of their sleep was protected more for caregivers in the active condition than the controlled condition. We haven't published those results yet, but we did present that in a scientific paper. And when I say we have been working very closely with University of California at Berkeley, with Dr. Bob Levinson and his whole team. So I think we're publishing some of the first results where a technology solution can actually meaningfully, significantly impact and improve the quality of life for caregivers. Just to wrap
Gene,
up
just a couple
here.
of minutes to go.
Okay, my last slide, and I won't take you through my whole long history, but I have done 5 startups and been really focusing in the area of AI, medical surgery, and cloud services. And however, at the very bottom of this slide, you can see that I do have both of my parents still alive. They're doing very well, but actually, I think one of the most important things that we can do is create solutions that help seniors age at home, have productive lives, and also help their families take care of them. That's what we're committed to doing. We've had some really early successes here in this area, and we look forward to continuing to contribute to this important mission of helping people age in the comfort of their own home with high quality lives. Thank you very much.
Terrific. Thanks, Gene. I appreciate that. Your focus on movement and the motion detection and some fall prevention is, as you know, super important. One of my colleagues in another division, the geriatrics and clinical gerontology branch, alerted me to the fact that the #1 cause of death among older adults is actually complications that ensue from hip fracture. And so,
Yes.
Anything we can do to try to prevent falls is good stuff as we get older. So thank you very much. I don't know if there are specific questions for you, but we can see if Alex has turned up anything in the email box.
Hi, yes. So we do have a couple of questions here. Many caregivers for the elderly are elderly themselves and may have issues in navigating new tools and technologies. How is this being addressed?
Very good point. That is absolutely true. And we have learned quite a bit about this topic that we didn't know initially. And so one thing that we have been doing is focusing on ambient sensing, which does not require behavior change. Once our sensors like these that I'm holding here are installed, they will just work invisibly. People generally forget about them. Fortunately, they don't look like cameras. They're not cameras, and they don't take video. So once you get them set up, then they tend to just work on their own. One thing that we've really focused on is using text as opposed to forcing people to launch an app. And, we previously came to this technology with an orientation towards the apps, and we still do apps, but we found it's too complicated and too much of a hassle to actually launch an app. So we've been using text, which is actually just a little bit more convenient to send out alerts. And then we are moving very quickly to support voice input and output. We haven't actually shipped that yet in these grants, but we want to. And I think just just enabling people to get a phone call and answer via voice, and then and actually that is something that my mom is very comfortable with versus, doing something fancy on her iPhone. That's not so good. So we're trying to make it as simple as possible to use and run independently. And then, the thing about the Apple Watch is it's actually pretty popular among seniors. So people understand in general what a watch is, and that they may want to wear it so that they know what time it is. But also we can use it to do fall detection and then pass the GPS location of where somebody may have fallen, whether it's inside or outside, and respond quickly. So we have actually worked on making it very approachable for seniors who are either caregivers or care recipients. But it is, you have to keep working on these things, and so the journey is a long one, but we have something that is quite simple to use, and we're continuing to try to improve that.
Thanks, Gene. I'd also note that your idea about communicating the information, whether it's to health professionals or to family, has to be just super valuable to families that are dispersed rather than those that live nearby, so that, remote children that live remotely from parents have a way of keeping in touch, keeping tabs in a way that it can't be done otherwise. So it's really cool. Thanks. I don't know if there's any other questions. I know that we only have about 3 minutes left in our time slot. So Shayla, should we take one more question?
Yeah, I do think we have time for that. And here's a question for, I think, several of the speakers. So somebody asked that the topic of ChatGPT has come up a couple of times. So the question here is for really all speakers: how do you handle data use and privacy issues related to OpenAI this time?
Great. So before answering, Gene, if you stop sharing your screen, maybe we can have you three turn your cameras on. And since Jay also talked about that, maybe she can chime in as well. But I'll step back, and Gene, since you're already there and you just talked about it, why don't you take first crack?
Well, I think privacy issues are super important. And one of the biggest pushbacks that we get is this thing looking at me? And we actually do support video cameras, but we don't say that. And we don't actually include it in our grant deployments. So not only are there extensive regulations for HIPAA compliance and so on, but also people get creeped out by too much technology invading their homes.
So Gene, let me interrupt there so that we can, I'm trying to be mindful of time. I'm timekeeper in my group. So let's have Jay, since you talked a bit about ChatGPT.
Yeah, so there isn't currently a HIPAA compliant version of ChatGPT that's out on the market yet. And so the tests that we've done, we've stripped out all sort of identifiable information and run the transcripts through. So all names, places, things like that, just as tests. There is one that's Microsoft is apparently working on that's coming to the market. So we're eagerly anticipating that. But for now, we're just using it as tests. We're not actually using it in the field live.
Great. And then Robert, did you have something to chime in on that front?
Not so much. I mean, we don't use OpenAI, ChatGPT at all, but there is certainly an interesting sort of case around sort of artificial intelligence and data privacy that I think is a much larger conversation for another day that I would love to dive into if anyone's interested. But yeah, so happy to share more later, but we don't actually use OpenAI or ChatGPT, but it's a very interesting topic.
Super. So guess what, guys? We're right at the time slot, 11:15. So, well, local time. So again, I thank all three of you for helping out in terms of giving, the perspective from the patient and caregiver. And I'm going to turn it back over to Alex and Shayla. And thanks again for helping out. Bye.